Bonjour, bienvenue, mesdames et messieurs. Thank you very much for joining us for another weekly research conference here at the University of Ottawa Heart Institute and also the entire region. And we're absolutely thrilled today to have Professor George Wells to present again, sort of another session of words of wisdom. And but before the lecture itself, just a few logistics. I think folks are generally very familiar now that you can actually pose questions along during the lecture in the Q&A feature underneath your screen. And we will endeavor to answer them at the end of the presentation. We'll also be accepting live questions as well. And so please use the hands up feature and we'll invite you to join the panel and you can directly ask the questions. And if you have any technical difficulties, please use the chat feature and Kelsey or Allison will be able to help you to make sure that you can access the presentation. And as almost everyone knows, Dr. George Wells is professor in the School of Epidemiology and Public Health at the University of Ottawa. And in fact, he was the former director of the school and also director principal investigator of the Cardiovascular Research Methods Center here at the University of Ottawa Heart Institute. Is also professor in the Department of Medicine at the University of Ottawa. And his research interests are wide-ranging, but tremendously accomplished in terms of the area of design analysis of large global clinical trials, evaluation of health technology, and the statistical methodology in terms of healthcare delivery and some innovative research methods. And he also helps and really devise a lot of tools for systematic reviews and meta-analysis and economic evaluation to help with the decision support technologies for patients and in the clinical practice. And some of you may know that my wife was the head of the clinical epidemiology and the clinical trials unit previously at the Hospital of Sick Children in Toronto. Always remind me regularly how lucky we have Dr. Wells here at the Heart Institute, and they had a vocation working together on several advisory panels with the Public Health Agency and other federal mandates. And so she certainly has the greatest respect of Dr. Wells. And I think we also been very fortunate that Dr. Wells has been instrumental in the design, execution, and analysis of many of the world-class clinical trials led by PIs, for example, here at the Institute and affiliated institutions. And these are presented at the major professional meetings and published in the topmost tier of high-impact journals. Dr. Wells taught at university, graduate and undergraduate level for 40 years, supervised 110 graduate students, and his courses are legendary and in fact form the foundation of many of the clinical researchers' careers. And he has worked extensive with national, international, governmental, and non-governmental agencies, as well as private sector partners. And he's been on the executive and steering committee of many of the major national and international research programs, trials, and as well as the evaluation of safety and efficacy for agencies. And he also is the associate editor of the Journal of Clinical Epidemiology and the editorial committee of the Canadian Medical Association Journal. And he's authored over 1,000 peer-reviewed articles. Pay attention. That's one with 3 zeros afterwards. He's been a principal investigator, co-investigator over 310 research projects. His H-index in Google Scholar 192. Yeah, I haven't seen too many of those. I didn't know that it goes up that far. And Scopus of 151. And he's been one of the highest cited scientists in the biomedical field several years in a row, for example, top 40 in 2017 and 18. So we're so privileged to have Dr. Wells to be amongst our research community and to really provide tremendous leadership and guidance for many of us here at the Heart Institute and the University of Ottawa. And so today we are privileged to actually hear talk on the topic of multicentre randomized trial ablation-based rhythm control versus rate control in patients with heart failure and high burden of atrial fibrillation, which is the RAFT-AF study, and the design, results, and lessons learned. Take it away, George. Thank you so much again.
Well, thank you, Peter, for the very nice introduction. That was very nice. Thank you. Yeah, so Peter's given you the title, and I had 2 or 3 different titles I could actually choose from, but I decided to go with this one. It's primarily due to the design, results, and lesson learned. I know that these results will be of particular interest to our electrophysiologists and heart failure docs. I think the design will be of interest to our basic scientists because it may give them some insights into the methods and procedures related to randomized controlled trials. And then finally, for our clinical researchers, I think not only will the design be of interest, but also the lessons learned. Over the years, what I've always done with a trial is at the very end say, this is a lesson I should have remembered, or the group should have remembered, and this is a new lesson learned, and put that into the pile to use later on. So hopefully the design, the results, and lesson learned will reach a number of you, and you'll find interest in it. Now, RAFT-AF actually it's a study that was funded about 10 years ago by the CIHR. It was funded in the range of about $4 million, so it wasn't a cheap trial. It was funded by the Randomized Controlled Trial Committee. The results were published in Circulation. The paper results were actually published 2 months ago in March on the main publication. And then in addition to that, it has been presented at international conferences, in particular the Heart Rhythm Society and ACC. But as I said, I really want to get into some of the design issues as well as the lessons learned in addition to the results. So going back 10 years and looking at the rationale that led to designing the study and getting the study funded, I'll give you a brief overview of that. So heart failure. So heart failure is increasing then, it's increasing now, it costs a lot of money. Heart failure patients may have impaired or preserved LV function. This is very important because we're going to be looking at subgroups of that in the results. So with impaired LV function, the management could include beta blockers, ACE, ARBs, aldosterone antagonists, devices such as ICD and CRT. With preserved LV function, treatment is symptom relief with diuretics or blood pressure control. Survival has improved for patients with impaired LV function, and mortality and hospitalizations remain high. We're also interested in atrial fibrillation. So it's a common cardiac arrhythmia. It impacts quality of life, leads to hospitalizations. It's associated with increased risk of stroke and mortality. And they occur in combinations. They frequently coexist. And the prevalence of AF increases in patients with more advanced heart failure symptoms. Why do they coexist? There's a number of reasons. AF can lead to rate-related cardiomyopathy. There could be loss of atrial transport that causes a fall in cardiac output. Heart failure causes increased atrial filling pressure and atrial dilatation promoting AF. Atrial tissue stretch caused by heart failure could promote AF. Now, these are the reasons we put in 10 years ago. There's actually a very nice article called Heart Failure and Atrial Fibrillation, like Fire and Fury, which looked at the coexisting of these two conditions. And it's got nothing to do with this character in terms of Fire and Fury, but has solely to do with a nice article by Carlisle and colleagues published in JACC in 2019, where they looked at a number of issues. In this particular diagram, looking at risk factors for heart failure, risk factors for atrial fibrillation, the pathophysiology, and then the combination of the two. What about treatment when you have both? The combined effects when you have both. There was a relatively old systematic review meta-analysis in 2009. And the reason I'm bringing this up is because this is actually one that was used in an editorial in Circulation when RAFT was published. So I thought I'd bring it forward. This was a meta-analysis that involved over 50,000 patients. And they noted that in patients with heart failure, that AFib was associated with 40% higher odds of death when they looked at randomized controlled trials. So the odds here is 1.4, highly significant. And when they looked at observational studies, the AFib was associated with a 14% higher odds of death among patients. And here the odds ratio is again 1.4 and statistically significant. So there is, when you look at the combination, heart failure patients, AFib is much more serious. In terms of treatment, we have an issue. Pharmacological therapy for treating AF is challenging. Pharmacologic therapy to suppress rhythm is problematic since many antiarrhythmic drugs may be pro-arrhythmic and have associated with increased mortality. Catheter ablation over the years to treat AF has become an effective therapy. And catheter ablation of AF in heart failure patients, is successful, as well as in patients without heart failure. So it seemed logical when we were designing this trial to postulate that catheter ablation-based rhythm control may provide heart failure patients with better AF clinical outcomes. So the scientific rationale for the study, well, the need for the study need better management of AF in heart failure patients. AF is recognized to be a major health issue. Evidence that heart failure patients with AF have increased mortality and morbidity. There's great progress that's been made in the understanding as well as the technique and technology associated with catheter ablation, and the feasibility and success of catheter ablation in heart failure is being recognized. So in summary, AF in heart failure patients is common, management is difficult. Recognizing high likelihood of heart failure progression with poor prognosis if we use good rate control, and catheter ablation is effective to abolish AFib, but still controversial if it improves mortality and morbidity. Then physicians are faced with the dilemma of allowing atrial fibrillation to persist and institute rate control as opposed to more aggressively abolishing AFib. Therefore, the time at that particular time was right to conduct a catheter ablation-based AF rhythm control versus rate control in patients with heart failure and high burden AF. And that was basically the background and rationale for the RAFT study. RAFT, of course, stands for randomized ablation. The F is fibrillation, the T is trial, and the AF is atrial fibrillation. Took great pride in the fact that these letters all started the word and was not buried inside the a particular word in itself. It is an international trial, primarily in Canada, with centers in Nova Scotia, Quebec, Ontario, Alberta, and BC. So we have a number of different centers. Also international centers with centers in Brazil, Sweden, and Taiwan. One center that's very important, of course, is the University of Ottawa Heart Institute. And these are some of the investigators at the Heart Institute over the years as RAFT-AF was being conducted. And Karen McDonald in particular was the site coordinator for the Ottawa Heart Institute. In terms of committees and labs, you'll know that with any large randomized controlled trial, you have a number of different committees and labs. In terms of, first of all, we have the coordinating center. The executive and steering committee are the decision-making bodies within a randomized trial. We have an external data safety monitoring board that looks after the safety of the patient. We also have an ablation and events committee, and we have core labs, ECHO and AF core labs. I believe that one of the most important centers in a randomized controlled trial is the coordinating center. They look after the day-to-day activities associated with the study. They look after the data management. They look after the analysis. And the coordinating center was here at the Heart Institute and the Cardiovascular Research Methods Center. Patricia Theoric-Patrick was the project coordinator and was assisted by Janine Ryan. And Mylin Tron was our data manager, and Lai Chen was our biostatistician. That's kind of some of the background to the centers and the various committees involved. So what's the primary hypothesis? Okay, it's the ablation-based AF rhythm control as compared to rate control reduces the primary outcome, which is a composite of all-cause mortality and heart failure events in patients with atrial fibrillation and heart failure. And the primary hypothesis looks across whether the LV is impaired, as given by LV ejection fraction being less than 45, or preserved, defined in this study as LV ejection fraction greater than 45%. The secondary hypotheses are very similar to the primary, except we're going to look at exactly the same primary outcome, but now in the impaired LV function group, and then we're going to look at it in the preserved LV function group. The study design itself is known as a probe design. It's a prospective randomized open blinded endpoint, which means that the study is not blinded except for the individuals who are assessing the results at the end of the study. The design is a parallel group design, 2 groups. So eligible and consenting patients were randomly assigned in a 1-to-1 ratio to either rate control, okay, which could be AV nodal blockers, BiV pacing, targeting a resting heart rate of less than 80 and a 6-minute whole walk heart rate of less than or equal to 110. The catheter ablation-based rhythm control will be using 1 or more ablations for AF with pulmonary vein isolation. Antiarrhythmic drugs will also be used, and so forth. There'll be the stratifications is stratified, sorry, the randomization is stratified by center and also by LV function being below or above 45%, as well as the type of atrial fibrillation. Key inclusion criteria. There's a long list, even this list is long, but patients with one of the following AF types will be included. They could have high burden paroxysmal AF, they could have persistent AF of various types, or they could have long-term persistent AF. They have to be on optimal therapy for heart failure for at least 6 weeks. They had to have a heart failure with New York Heart Association class 2 or 3 symptoms. They could either have impaired or preserved LV function. They had to be suitable candidates for either catheter ablation or rate control when their AF was treated. They had to be 18 years of age or older, and their NT-proBNP, okay, had to be at a certain threshold as identified in this table, depending upon their current rhythm and whether they've been hospitalized in the last 9 months for heart failure. Primary and secondary outcomes. As I noted, the primary outcome is a composite of all-cause mortality or heart failure. Now, heart failure is a relatively new definition. We took the definition by Hicks et al. In her article in JACC, which is one that's accepted by the FDA. So the heart failure event was defined as an admission to a healthcare facility for greater than 24 hours, or clinically significant worsening of heart failure leading to the administration of an intravenous diuretic and an increase in chronic heart failure therapy, an emergency department or unscheduled visit to a healthcare provider. We also look at a number of secondary outcomes. In particular, we have to look at the composites of the primary, in this case, death and heart failure event. And we also looked at the change in LV ejection fraction, NT-proBNP, the 6-minute hall walk, and 2 different quality of lives. And we looked at that at 12 months and 24 months. The primary and secondary objectives were evaluated in all patients, as well as in patients below and above 45% LVEF. And subgroups were also, and these were unstratified subgroups. We looked at it by sex, diabetes, hypertension, underlying heart disease, and New York Heart Association class. So this is the study methodology. So in any randomized controlled trial, you have a whole raft of activities, a little pun on raft, a whole raft of activities as you progress through. So we screen patients with high burden AF. They have to satisfy the inclusion exclusion criteria. They have to provide consent. We also measured their NT-proBNP either at the screening visit or baseline. For those eligible and consenting, at baseline, we do their history and meds, their physical exam, ECG, quality of life, 6-minute hall walk, and then possibly at this point, we do the NT-proBNP. We also did a clinical echo. We randomized them into our 2 groups. At 2 and 4 months, we're going to look at, again, their history, their meds, their physical exam, ECG, 6-minute hall walk. At 6 months, we repeat that, plus have a 14-day continuous ECG monitoring. At 12 months and annually, again, we repeat it. And we also do a clinical echo at that point. And every 6 months between these annual visits, again, we do a number of evaluations very similar to before. And again, the 14-day continuous ECG. So you see there's a number of assessments that are made over the time that a patient is in the study, and of course, over the complete timeline of the RAFT study. Now, in the initial sample was 600, 300 in each group. This was based upon a 30% relative risk reduction in the primary outcome, a 30% reduction in the hazard ratio and the primary outcome. However, in July of 2018, recruitment was stopped. It was stopped on the basis of the recommendation of the Data Monitoring Committee after they did an interim analysis. The enrollment at that time was lower than expected. The event rate was lower than expected. And there was a measurement of futility, which is you calculate a futility index. If it's above 0.8, then you've got perceived futility. And that perceived utility happened when there was 363 patients that were followed for approximately a year and a half. I will come back to this point later in the presentation as one of our lessons learned. Okay, this is the patient flow. We ended up with 411 patients in the study, 197 in the rate control group, 214 in the ablation-based rhythm control. 9 of the patients in the ablation group did not get the intervention. Some refused ablation, for example. There was also one for a tapenade, did not get it. As we follow them through the study, the median follow-up was just over 3 years, with the lower quartile being 2 years and the upper quartile being about 4.5 years. There was 11 individuals were lost to follow-up for various reasons in the rate control group, 5 in the ablation-based rhythm control group. But for the analysis, and then also we had crossovers. We had 7 that crossed over from rhythm to rate, and we had 2 that crossed over from rate to rhythm. The intention to treat, of course, we would include everybody who is allocated to the rate control group in that analysis, and in the intention to treat for the ablation-based rhythm control. Again, we included all 214. So it included everybody. And that's the conservative way of looking at the analysis in a randomized controlled trial. These are the baseline characteristics. I know it's a long list. I'll just highlight that we're talking about individuals in their mid-60s. 3/4 of them were male. And the only other one I'll highlight is at the very, very bottom, because we're going to be looking at the ejection fraction below and above 45. You can see the numbers broke 116 versus 124 within that strata, and 81 versus 90 within the preserved LV function strata. Just to show you that things did work, the percentage of patients in AFib or flutter at time 0 in the 2 groups was 80 and 87%. In the ablation-based rhythm control group, it dropped to below 20%, was maintained very much so right through the whole length of the study, even to those who were followed for nearly for 60 months. Whereas in the rate control group, it was high and it remained high. This is the primary outcome. And you should observe this graph very closely because we'll be coming back to it later. So we're looking at the primary outcome, all-cause mortality and heart failure events occurring over time. These are the descriptive Kaplan-Meier curves of the time to these various events occurring. You can see that the ablation-based rhythm control group, which is in blue, seem to be doing better than the rate control group, which is in red. Okay, how much better? Well, we saw a 29% reduction in the hazard ratio, but it was not statistically different. It was 0.06. It missed the magical 0.05. I'd like to draw your attention to that 18-month period, about a year and a half in, where we had followed those patients, produced that analysis for the Data Safety Monitoring Committee. And you'll notice at that particular point in time, these two curves are relatively close together. And it was after that time point, in particular after 2 years, when they started to separate. Okay, I'll come back to that in 10 or 15 minutes. What about our secondary hypothesis? Because we wanted to look at that primary outcome of the combined death and heart failure hospitalizations, both within those with impaired LV function and those with preserved. And if you take a look at the impaired, the curve looks very similar to the overall group. Okay, it kind of starts to separate around a year and a half to 2 years, with the ablation-based rhythm control doing better than the rate control. And the hazard ratio now is actually a 37% reduction with a p-value of 0.059. When you go over to the preserved group above the 45% LVEF, you can see that the curves are more closely related throughout the whole time course. The hazard ratio is only a minor drop of 12%, and the p-value is 0.6, nowhere close to anything statistically significant. So that's the primary outcome of all-cause mortality events in the whole group, as well as our two subgroups of interest. There are other outcomes, and this table summarizes it. Don't look at it too closely because I'm going to show you a graph on many of these outcomes. But I will be looking at the primary outcome in terms of its components, which is always good practice. If you got a composite outcome, you should always look at the components of the composite. We're also got a number of supporting secondary outcomes related to quality of life, 6-minute hall walk, and biomarker NT-proBNP, as well as the change in LV ejection fraction. So let's take a look at these. So first of all, in terms of the components of the primary, all-cause mortality, when you look at all-cause mortality, you're not really seeing any difference between the two groups. Not very little difference at the 2-year mark and at the 5-year mark. The hazard ratio is down about 0.2, 20%. P-value is nowhere near significance. When you look at heart failure events, and in heart failure events, we have to be very careful because we have to adjust for what's known as competing risks, because you can't have a heart failure event if you're dead. So and dead for whatever reason, in particular, maybe for a non-cardiac reason. So we have to adjust everything for this competing risk. And so for the heart failure events, we see about approximately a 30% reduction with a p-value of 0.12. Of course, so when you combine these two, you start to see something, but individually, certainly the mortality is not there, but the heart failure events is starting to approach something that may be meaningful. These are the supportive secondary outcomes. I try to summarize them here for you by what the supporting secondary outcome was and which group we're looking at. Was it all patients, or was it in the subgroup of impaired LV function or preserved LV function? I highlighted in green anything that became statistically significant and favored the ablation-based rhythm control. I highlighted in yellow anything that was not statistically significantly different between the two. And then I highlighted in red anything that favored rate control in a statistically significant fashion. And of course, there is no red. So looking at each of these, and I'll go through the first one with a little bit of care, and the second one then the others will follow in a very simple fashion. So this is looking at the secondary outcome of LV function. We're going to be looking at it in our 3 groups, all patients and our 2 LV function groups. We're going to be looking at what's plotted here is the change, okay, in LV ejection fraction compared to baseline. It's a change that is based upon a model because we had to do a general linear model on it. I won't go into detail on that, but basically what you're seeing here is a change from baseline at 12 and 24 months in the rate control group, and the blue is the rhythm control group. And that's repeated in the other 2 groups of interest. The effect size, okay, is an effect size that takes into consideration time, and it also takes into consideration the competing risk of death. This is a relatively sophisticated model that uses, it's called a joint model, where we know that we can't look at LV ejection fraction if somebody's dead. We still have them going over time. And so we build this very sophisticated model. And based upon that model, you're seeing a statistically significant reduction in LV, difference in LV function for the ablation-based rhythm control being better than rate control for all patients, for those with impaired LV function, and for those with preserved LV function. Okay, and that's what the green, green, and green stands for. We're going to be looking at Minnesota Life Living with Heart Failure Health Quality of Life questionnaire. And you can see that, I won't go again through the explanations, but you can see that in this case, a lower score is better. You can see that the rhythm control, the mean change from baseline is doing better than the rate control. And again, we've got statistical significance for all patients for the impaired, but not for the preserved. Again, it's a little bit higher. When we looked at another quality of life questionnaire for the AF Effect Quality of Life questionnaire, again, now it's a higher score is better. You can see that the ablation-based rhythm control is doing better, okay, than the rate control. And again, it's statistically better, and not statistically better in the last case, although it is below 0.0 or 0.10. The 6-minute hall walk, again, better in the ablation-based control group, again, significantly better in the all patients and in the impaired LV function. And then for NT-proBNP, it is statistically better in the all 3 of our groups for the ablation-based control group. And you can see the drop off here, okay, for in the ablation control group is more significant than the drop off in the rate control group. Okay. So, and this is just a composite of all of these, where the blue line should be better than the red line if you're favoring ablation. You see it for the LV-EF, you see it for the AF-E2 equality questionnaire, you see it for the 6-minute hall walk, where it's supposed to be below. If you're on the side of ablation, you're seeing it for the Minnesota Living with Heart Failure, which should be lower because lower is better. Okay. This is the subgroup analysis. We did all the standard subgroups that we planned for. The only one I'll draw your attention to is sex, and females seem to be doing much better than males when it comes to ablation-based rhythm control group control. I'll leave that to our heart failure and electrophysiology cardiologists to tell us why, if there is a reason, but it is not, the p-value for interaction is not statistically significant, but definitely it is as a subgroup is statistically significant. In terms of serious adverse events, we found no difference. So basically 50% in each group for all events. Cardiovascular is in the 30s, non-cardiovascular was in the high 20s. We did see ablation-related ones being high in the ablation-based control, as you would expect. These are the reasons, and very few related to device implant leads or AV nodal ablation-related adverse events. So, what is the summary of this? First, in this trial of patients with atrial fibrillation and heart failure, the reduction of all-cause mortality and heart failure events with ablation-based rhythm control did not reach statistical significance as compared to rate control. Remember, it was 0.066 or 69. Patients in the ablation-based rhythm control group had numerically fewer primary outcome events and greater improvement in LV function, quality of life, reduction in NT-proBNP than in the rate control group. And thirdly, there was no difference in the number of patients with serious adverse events in the two study groups. Okay. So I want to spend 5 minutes now talking about lessons to remember and lessons learned. Okay, lessons to remember. I want to draw your attention to clinical versus statistical significance. We published this paper in the Journal of General Internal Medicine back in 2002, 2 decades ago. Okay, what's the difference between the two? And we looked at different types of studies that fell into different categories. First of all, in terms of statistical significance, the way I look at it in this diagram is that we have this dotted line, okay, which is the neutral value. So that could be a relative risk of 1 or a hazard ratio of 1. Anything to the right of this will favor the control group. Anything to the left of this will favor the experimental treatment group. We make the judgment on statistical significance, in this case, by looking at the confidence interval, okay, which consists of the point estimate of our hazard ratio, and its 95% confidence interval. And you can see that in some cases, if the confidence interval, upper confidence limit, lies below this line, we say statistical significance. If it lies above this line, we say it's not statistically significant. So you can see we've got 3 cases of not statistical significance here, here, and here. But then we move into clinical significance. And to talk about clinical significance, we have to talk about what is the minimal clinically important difference that you think is important. So for example, if this X represents the minimal clinically important difference, and the types of outcomes that you're getting, the types of point estimates are much lower, okay, than that minimally clinically important difference, that means something to you than if it's higher, okay? Also, it may mean something different if this minimal clinically important difference lies within the confidence interval than if it does not. So the 2 extremes here are quite easy. If you've got something that's not statistically significant, and this minimally clinically important difference is greater than that upper confidence bound, then it's not statistically significant, and it's definitely not clinically important. That's the opposite end, where you can say it's definitely not clinically important, arises in 2 cases. And those 2 cases arise when you do have a statistically significant result or you do not, but the minimal clinically important difference is excluded by the lower confidence limit. Okay, and this particular case can arise here if you have a very, very, very large sample size that produces a very, 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 very tight confidence interval. But that confidence interval, the only reason it's statistically significant is because of the tight confidence interval, but the difference you think is minimally clinically important is actually excluded. The 2 cases we want to look at is when do you get something along this line, okay, that a probable, okay, is a case where it's not statistically significant, but the point estimate's below the minimal clinically important difference, okay? In this particular case, it's possible because it's below the point estimate, but it's within the confidence interval. And that's basically what we have in this study. Our minimally clinically important difference was a 30% reduction in the hazard ratio. We saw a 29% reduction overall, very close. We saw a 37% reduction in the impaired LV function group, which is below that, which falls in this case, which one could call probably clinically important, but not statistically. Or if you even look in the LV, in the group with preserved LV function, you can see that it's included in the confidence interval. So one could talk about it possibly be related. So that's just a lesson to remember from way back. But what about lessons learned? Okay. Now, this is going to be the more interesting one because it's a lesson learned, and I learned my lesson. Sample size was calculated at 300 per group. The minimal clinically important difference was 30%. We did a log rank test. We put all the appropriate ingredients into it. We had an O'Brien-Fleming evaluation partially through the study with an appropriate spending function. So everything was set with 300 per group. Then we had a futility analysis. And what a futility analysis would be is that at some point a decision is made, or possibly that it's a futile situation. Your hypothesis you'll never be able to assess or show your hypothesis. Okay, it's futile. Okay, and in June of 2017, our data monitoring committee reviewed our planned interim analysis that we had done when 33% of our patients, 1/3, which was 209, were enrolled, and they were followed for a minimum of 1 year. On the basis of that analysis, the DMC requested that we do a futility analysis, and they wanted to conduct it on all patients that were enrolled and followed to the end of September 2017. We did that. In September of 2025, the DMC recommended that enrollment be terminated and follow-up be continued for another 2 years. And we implemented that in January of 2018. That decision was based upon a number of reasons. One was a lower than expected enrollment. We were struggling with enrollment, as we often do in randomized trials, and also the perceived futility. So there is what we call conditional power. The conditional power was only 19%. So our power was only 19% to find a difference based upon the information we had at that particular point in time. Okay, so this recommendation was brought to the steering committee. The steering committee agreed, and we went into stopping enrollment. Okay, these are different reasons for stopping it. So after my lessons learned, as you'll see, I decided to take a look at this. Time saving is one advantage. If we're facing slow recruitment and the study's going on and on and on, maybe some of the things that you're doing may longer have relevance in today's world. You may want to stop the study. You may want to use your research funds in different areas. You may want to reduce participants' exposures to potentially harmful treatment, and also earlier dissemination of information about the treatment. Certainly, this was one of the reasons that we had in the back of our minds. What are the disadvantages? It leaves the research question without a definitive answer. It's difficult to interpret a negative result. You have wider confidence intervals because your sample size is smaller than if you continue the study to the full sample size. There's an increased risk of imbalance in some prognostic factors. It alters the analysis of some of your secondary outcomes. In this case, like quality of life or 6-minute hall walk or NT-proBNP. Your adverse event data is more limited because you have fewer patients. It's unlikely that if you stop something for futility that somebody will actually pick up the trial and do it in the future. And you have to think about the effects of this research on the totality of the literature in the field, in particular when one looks at meta-analysis and so on and so forth. So there's some of the advantages and disadvantages. There was a very nice publication on a systematic survey, didn't call it a review, of randomized trials that stopped early. They found 52 trials. Who made the decision? Usually investigators on the basis of the DSMB, which is what our case was. So 30 of the 52. How much information was available? We had less than 40% at that particular interim analysis. And so between 11% made that decision at that point versus say 20 with a bit more information. The reasons for the stopping, you could have multiple ones, and you can see that we had many of these. We mentioned futility, we did conditional power, and so on. Futility was explained. Again, we reported the conditional power and so forth. We reported we're in the minority, only 20% actually report the conditional power, which we did do. So there was a very nice survey on this type of thing. What are the consequences? And these are the consequences that really bothered me. These are the consequences that are a lesson learned. Going back to this original Kaplan-Meier curve I showed you, you can see that when this decision was made primarily on data in this period of time, you saw a separation of the curves afterwards. Who knew? Okay. And in the final analysis, if we had continued following the patients for another 3 to 6 months, our p-value would have fallen below the magical 0.05. If we had 1 to 2 or a fraction in between of events occur in the rate control arm, we would have got statistical significance. We never expected this to occur, okay? We expected the p-value to remain quite not significant, 0.2, 0.3, 0.4, but the separation occurred at a later time period than when the data was actually assessed. Now, there's a very interesting series in New England Journal of Medicine called The Changing Face of Clinical Trials. And they have one paper called The Primary Outcome Fails, What Next? So this is looking at primary outcomes that fail to reach a prescribed endpoint, and can any clinically meaningful information be derived from it? Hopefully my answer to you is yes, as I went through clinical versus statistical significance. But in this particular study, our bottom line conclusion was no difference, okay, was identified. No statistically significant difference was identified. There was an editorial published on this. One of the authors who I know quite well, which is Chris Granger, who I have a lot of respect for, very critical, but usually has very insightful INSIGHT comments. And they also had them here. They noted that management of atrial fibrillation patients who have heart failure requires a little bit more considerations. They did notice this meta-analysis that had higher death, okay, among AFib in fibrillation if they were heart failure versus not. They noticed that more recent clinical trials after this meta-analysis did find that catheter ablation for AFib improved clinical outcomes, in particular in patients with heart failure. And they noted the Amica trial, the ATAC trial, the camera MRI, Castle-AF. They noted the subgroup within the Cabana. But they did notice that any additional randomized data comparing the clinical impact of ablation control in patients with heart failure are welcome. So they then go on and say, well, in this issue, Parkish et al. Reported on the RAFT trial. They noted that the RAFT trial was stopped early on the basis of the recommendation of the DMC. But remember, it's just not the DMC, it's the steering committee as well. However, the results at the end found a modest but not significant 29% risk reduction, just missed statistical significance. But the secondary outcomes all favored the ablation-based rhythm control group. Their remarks: unfortunate trial was not completed as planned, provides an important cautionary tale to DMC committees about early stopping. And nevertheless, even before the RAFT-AF trial results were there, evidence was building for a benefit of catheter ablation in patients with heart failure. So that's the lesson learned. It's a lesson learned for me because I have never seen, after such a decision was made, all of a sudden the Kaplan-Meier curves separate. Okay, so I agree with the editorial group, the two authors here, that the trial should have been completed as originally planned. But further thoughts on the results, taking this into consideration. Last slide. An interpretation of the results, an interpretation of the results is there's no effect of ablation-based rhythm control over rate control as it relates to all-cause mortality and heart failure events. An alternative interpretation is there is a benefit. However, fewer patients were included than originally planned. There is a time delay before treatment takes effect on mortality and heart failure events. Don't know why. There appears to be a differential effect of ablation-based rhythm control over rate control between patients with impaired versus preserved ejection fraction. And this study warrants further investigation for ablation-based rhythm control for the treatment of AF and heart failure, which may reduce mortality and heart failure events. I believe that some of our electrophysiologists and heart failure physicians will be able to maybe shed light on why we saw this later based differential in heart failure and mortality. and I'd be interested in comments to that effect. So that's it. I hope that I kind of hit some buttons, maybe emphasizing results. I'd be interested in certain clinicians, giving you some background to design for those who do not usually look at randomized controlled trials, and then the lessons learned. And that's it. Thank you very much.
Wow, thank you so much, George. Yeah, this is unbelievable. What a great case for illustration. I guess that's the number one.
Yeah.
Number two is actually extremely valuable trial, because I do heart failure. I look after these patients all the time. And I absolutely agree with the clinical interpretation of the data. And I would, but I have some thoughts about, why the statistical aspect may not come out and what the mitigation strategy could be. But let me see if there are any questions. Yeah, so please ask a question in the QA or raise your hand, because otherwise I have so many questions I'll take.
Yeah, you'll ask it.
Yes, right. So a couple comments. One is that, of course, this is a timely question. And then now, with more data, exactly as the editorial says, the nice thing is that all those studies are all consistent.
Yes.
None of them were powered, by itself to get over, I guess, that the statistical, magical threshold 0.05, but the curves are all kind of look very, very similar, so there is a underlying biological validity and the clinical validity.
So this is begging for a nice, well-designed meta-analysis, but anyway.
Absolutely, yes, exactly. So that's always, sort of the, I think the opportunity in which one can take advantage of, to really have a definitive answer. Two comments, and then I want a suggestion. Let me see. Oh, Dr. Masana has his hand up. That was a message. Okay, so is Kelsey able to bring Dr. Masana in? Yes. Okay, so please ask your question.
Well, I think it's a fantastic presentation, George. I have, when I was listening to you, to me, it raised always a question that randomized trials are not reflecting the real world. And this is probably why actually it unfavored the catheter ablation. Each time you compare someone with a procedure with someone who doesn't have a procedure, in the real world, people who don't have a procedure, they don't have the same follow-up. In this randomized trial, obviously, you took very good care of the people who didn't have a procedure. And in real world, it doesn't happen. So I think, to me, it's clear that in the real world, catheter ablation will deliver better results. Because it's not going to happen that people with no procedure would have such a careful follow-up for 2 years. In particular, in Canada, we know many people with atrial fibrillation are just not seen. And here in this trial, you have seen them. So you have actually improved the care of the people without procedure. And this is why there is a bias introduced by the fact this is a randomized trial, so people are very well taken care of. And I would imagine, I was very surprised by the low rate of stroke and hemorrhagic complications. I mean, because this is the main problem of atrial fibrillation. How do we prevent? Is it to prevent stroke, right? That we do these procedures, not just to prevent heart failure. That was my two comments. Kind of, if you have, I'd like to hear your thoughts about this kind of a real world versus not real world that can have actually disadvantaged the procedure side of the randomized trial.
Yeah. So as an epidemiologist, I use all, and one who's interested in intervention studies, I use the full spectrum, okay, all the way from very tightly controlled efficacy randomized controlled trials all the way through to observational studies. But let me just stay within the randomized world just for a second. If you can take a look at my screen and view that as an illustration on a chart. On the vertical axis, we would have what is the likelihood or risk of someone experiencing an event. And on the horizontal axis, we'll have what is the likelihood of or probability of someone doing well on our intervention. And in an efficacy trial, what we do is we take patient and a very tightly controlled efficacy trial, we take patients who have a chance of having the outcome high and a chance of being of benefiting from the therapy as being high. So we look at basically this corner here, going from low to high, and that's called an efficacy trial. And after we show that something works in the ideal situation, then we loosen these two avenues. And so we take more patients, wider group, we take less, so we get more of a pragmatic study. And so we move from the effective efficacy style study and take the whole spectrum, which is your effectiveness studies. And then once you get that, then I think once you show something works from an efficacious and effectiveness perspective, that's when you put it into the real world setting. So I view it for the full spectrum. And we do a lot of work in post-marketing surveillance of drugs and devices, but primarily drugs. And that's where you can find a lot of not only the efficacy side of it, the safety side of it, you also pick up on some of the efficacies. So I agree with you. I agree with you that you need to look at it. But I also agree. I also believe firmly that the RCT has to show that the starting point is worthwhile, because later on, if it doesn't work, then it doesn't help. But you have
and don't forget, you compare a strategy that costs billions of dollars to one that costs very much less money.
Yeah, so one of our items within the RAFT is to do the economic evaluation. So we got what's called a Markov model, and people flow from one cell to the other. And so we can look at the quality, and that's the reason why we measure quality of life. So we can look at a quality, we can look at the cost, and then we do a cost effectiveness or cost quality analysis.
Yeah. So actually, David, thanks for that question and answer. But so I may make just a few comments after. But David Burney has a question, which I think is also very important, because David, do you want to ask, or I'll ask David for David then? Yeah. So he asked the question. So in terms of the question is whether there are any plans for other similar trials, because now we have so many new heart failure medicines that are actually changing outcome. So this is actually part of the reason that the events rates are getting lower and lower, is because heart failure docs, and have to declare conflict of interest here. Heart failure docs have been doing heart failure trials as well, and we have newer treatments that actually, and in fact, that's the challenge of new heart failure therapies, that the mortality and hospitalization no longer what it was.
Yeah. I think it's a very, I'm not sure if people can respond to that, but maybe as they're thinking. That's why I made very clear at the very beginning that some of my background was background from 10 years ago, because of all the changes that have occurred. I think it would be very interesting. Maybe David maybe you should design one. I'll help you out, but I'm not going to ever stop it for futility. but I think it's a good question. Thanks, a very good question.
Yeah, so I have a question, and then I have a suggestion, and then the suggestion, in fact, for the trial that David is going to run. But I will help David for a change this time, because you need a good heart failure doc on these trials. That's where you missed it. So the question is, and I guess it's a bit similar to what Dr. Massan was asking earlier. Because of the fact that there appears to be a bit of a cost or attrition to the one of the arms, right? And this is typical of a procedure, in which there are some temporary, sort of issues, obviously, and then the benefit takes over, right? This is where the remodeling, because, no question that the heart wants to be in sinus rhythm. That's the way it was designed. And then, so all the remodeling takes time. And so, hence all the benefits that accrue over time. And so that in that case, then the futility analysis may actually be, misleading, right? because you have this kind of artificial crossover that may not be taken into account in the original design of those indices. And so that was, my question about futility. But my suggestion, and this is where you have, done so for some of my trials, and that is that to include these are hierarchical endpoints. So some people now use win ratios, because of the fact that to the patient, when we ask them, mortality is not the endpoint that they're interested in.
Yeah.
Hospitalization, yes, but it's actually the other endpoints, right? Quality of life, and these are things that the patient really care about. And when you actually, do the hierarchical endpoint, in fact, you will be able to, achieve statistical endpoint, and it's also relevant for the patient as well. And so maybe that's a way to potentially do this. As
That's actually a good point. So in the Markov model for the economic valuation, you got in different stages: hospitalization, death, of course being absorbing stage. But we're going to be looking at quality of life. And so when you do the cost per quality, that'll be the way to actually do it. And then. And so there may be an improvement in quality of life. There may be a greater cost associated with it, and you want to look at the balance between the two.
Yeah.
And
So do you think the futility analysis may not be that applicable, when you actually have a situation like this?
No, and as you see, we've got a lot of supporting variables, and when we do it, we're going to be using the quality, not the mortality.
Yeah. Okay.
Good.
So I think if you have time, so we may wrap this up, but this is just absolutely fascinating. There are so many aspects. The other beef I had, you actually mix half-ref and half-PEF together, which are two complete different conditions, which I can tell you from day one when we did the original publication. But nevertheless, still every trial we learn so much from it, and this is a great illustration. And so we constantly. Become smarter as we go forward, with the thoughtful, sort of studies. Yeah. So just thank you so much, George. This has been a fantastic, experience. Number one, two is that involving, so many of our investigators, and it's really valuable trial, and there's so many lessons learned at the same time. Yeah. Thank you so much, George. Yeah, and so I will touch base with you to get your help on my trials.
Yeah, okay, very good. Take care. Have a great day.
Yeah, thanks everybody for joining us. This has been a sort of a really excellent session. And next week we'll have Dr. Christopher Sun, who's actually our new AI recruit jointly with the Telfer, who's actually a health system analyst, and you're looking specifically in terms of how we can improve our care on the system level for patients with cardiovascular disease. I think you'll find the presentation absolutely fascinating. So thank you so much, and look forward to joining us next week. Take care. Bye-bye.